This is Nakala Hospital in northern Mozambique 30 years ago. And this is me. and this is my wife. This is another Swedish doctor ended up. This is what became the district medical officer, Antonio Tanda, who was the first assistant stomatologist in Mozambique, trained in that. The other is the staff. This is government health service. I was not working for any aid organization. I was an immigrant doctor working on a contract directly with the Minister of Health as part of the health service. And everyone here with white dresses have some form of formal education. The others are nurse aides and so on, working at the hospital. Fantastic, nice staff. The normal nurse here, Hannibal over here, he had 4 years schooling and 1 year professional training. Amazing situation in Mozambique with so little preparation and so much dedication that we saw. This was just 5 years after independence when we came to work in Mozambique. And these are the staff, the day shift of the hospital for 300,000 people. And the fourth biggest city in Mozambique with 80,000 people and an international port. It was an absolutely amazing difference in resources. We had cases, classical, can anyone make the diagnosis? 10 days after delivery? Tetanus, yes, rhesus sardonicus. Huh? She had had one national campaign of tetanus vaccination. She had had one injection. So she had a mild form of tetanus, and we managed. And this is mainly to show Mama Rosa, the parteira bee, the bee midwife, but was the old midwife trained, so wise, my main mentor in medicine, who really know what could work, what was realistic to do, and who taught me ethics. Never do a fetotomy without having the permission of the family first. And that permission was easy to get, but never ever misdo that. Never handle any delivery as a technical issue. And always see that all miscarriages would have their fetus so that they could bury it. I'm very much in depth for her. And it was very nice to come and work with this. This was after the war period and before the next war to come in Mozambique. So it was a very, very important period. This was the district in northern Mozambique, population 300,000. I was the only doctor 1980, 1981. We were two. We had 3,000 children dying every year in that area. So you know that every second hour a child was dying under your responsibility. But you are not seeing them in the hospital, but they were under your responsibility. Because our responsibility was not the hospital. It was the population, very clearly, explicitly. I was district medical officer in charge of the health of 300,000 people. I should have been in the district government, but the foreigner couldn't be that, so there was a nurse who was there to me. We worked together. This is the district I worked in Sweden. Gävleborgs, we had on the same area, we had almost the same population. We had 800 medical doctors instead of 2, and we had 30 child deaths instead of 3,000. And we had 5 hospitals, but otherwise the size was similar. And what I learned was that there were 2 zeros more resources in Sweden and 2 zeros more need in Mozambique. 10,000 times difference in need in relation to resource. This caused in me a severe 00 traumatic syndrome. And I'm spending my life trying to recover from this. I was always interested in seeing things. I was a keen clinician. I trained in internal medicine, you know, and I like clinical medicine, you know, but I also wanted to make sense of it. And this to me, realizing that it's 2 zeros differences. Whether it's 8 here or 6 or 2 doesn't matter. I had to do the work every day I went to work. I had to do the work of 100 doctors in Sweden. So what should I do? Work 100 times as fast or just take care of 1% of the patients? Those were the options, obviously. And it's difficult sometimes to realize when you move from this is not typical for industrialized countries and developing countries. This is one of the most lucky countries in the history of the world. Sweden, who are kept out of all the wars, you know, had a thriving economy, a stable political situation. And Mozambique, some of the most unfortunate countries in the world through colonial times and wars and so on. It's the extremes of the world. But really, it's impossible to grasp. And I lived there with my family, my wife, my kids. I went up in the morning, we had breakfast, I went to work, and I had to work, but I had to do the work for 100 persons, you know, with 100 times the need. It takes a lot of priority. You have to choose what to do. The most important is not what you do, how well you do it, but what you choose to do, obviously. This was the intensive care unit. 2 children with severe hookworm anemia, pneumonia, and cardiac insufficiency. Complex like geriatric patients in Sweden. And here are the most important staff. Xavier, who was the nurse, the 2 nurse assistants who spoke Makua and could convince the mothers that the kids needed blood transfusion. Lino, proud laboratory assistant who had done the blood grouping. No blood bank, but the maternal uncles of the children would always give blood. Matrilinear system. The father could never give blood to his children, but the maternal uncle would always do it, without no problem. And the most important there, the head of administration, who got the salary and paid this. You run hospital with salaries. That's what I learned. I had 3 months without salary for the staff. Very ugly to run hospitals without salaries. It's all about money. And from this period in Mozambique, I came to the conclusion, I love money. I really love it, because I know so well how to use it. Don't you ever think that you can provide health service to a population without money? And then, of course, these children, but we knew that some decent latrines, some safer water, you know, some preventive care would have avoided this. But this was where we could save life, and you could really, really save life, you know. And then you have exactly the same room 30 years later. My wife and I went back and spent time there, and this fantastic skilled staff now using this room for their HIV treatment control. And the old hospital was now the health center for the city, and a brand new hospital was built. And where we had very meager conditions were now decent. This is my wife admiring the new delivery ward. With trained staff. And what was especially different was the professionalism of the new staff now in Mozambique. We were really happy. We thought it was a miracle what we saw now 30 years later. Here is Dr. Fernau, who was now head of health service in the city, sitting in my room where I had at my office. It was nice when you came back. Someone asked me, did they remember your legacy? And people said, you come back. We have worked there. Oh, have you worked here? Yes, 30 years ago. Oh, there are old people coming here. They worked here before. When did you work? Well, I worked here. Said, yeah, we remember you. You had that motorbike. And you went, no, I never had any motorbike. Not one single person who had heard about us. Not one single person who had heard. But I had such a bad YouTube connections also, they hadn't even seen me on YouTube. Of course, when we went to find the people we work with, who all had retired now after 30 years in health service, then there was very friendly meetings and we had wonderful time together. But in the health service, we were completely forgotten. Completely forgotten. And still, we loved coming back. We loved coming back. It was like really coming home, because we lived there with our children. They went to school. We were so well received, so well welcomed by the society. And they didn't say, you are the doctor in the city. No, you are Anna's father, in the gentle and nice Makua culture where you are the parents of your children. That's the most important. So living there with children was a fantastic experience. And we could go back and live there. It's really emotional how you can adapt to a society you have worked with. This is Dr. Fernau's reality today. Instead of 300,000, there are now 600,000. 300,000 people have doubled. The population have doubled in Mozambique over these 30 years. And instead of one hospital, they now have 2 hospitals. And instead of 2 doctors, they have 16 doctors. I don't calculate 1980 because that was a especially bad year when I was alone, but 81 we were 2 doctors. So what does it mean to go from 2 doctors to 16 doctors in 30 years? It means that you have doubled 2 to 4 to 8 to 16. It's 3 doubling, isn't it? And if you have 3 doublings in 30 years, you have 1 doubling in 10 years. And if you double in 10 years, what is your annual growth rate in percent? MSF only use Word, you don't use Excel. It's a privilege of humanitarian aid, you don't have to count. 70 divided by the growth rate in percent is the doubling times in years. If you double in 10 years, you grow with 7% per year. If you don't know this, you can't follow what happens in society. It means that the number of doctors... No, it's serious, it's serious, it's serious. This is 7% growth of doctors per year, and the Mozambican economy is growing today with what? 8.2% per year. This is what you can expect. You can't grow faster than this. You cannot grow faster than this. And to many who would come today would be appalled by the lack of health resources in this district in northern Mozambique. To us, it was a miracle to come there because we compared to 30 years ago. A miracle on how good the staff was and how it functions, you know. But when we went to the northern part of the district, where I rarely came beyond this point, we never had a pregnant woman who came beyond this point for delivery here. They all died at home. And when they came here and needed a cesarean section, we had to send them 200 kilometers away. Here we did fetiotomies. I did so many fetiotomies. And symphysiotomies and vacuum extractions. We could do a lot of, and blood transfusion and so on. We never had anyone from up here, but now there was a hospital here. But still you had 13-year-old girls coming in with transversal lie and uterus ruptures here. But they came here, now they only had to go here, and they did 300 cesarean sections per year with good indications. Miracle. Miracle was that. 7% growth rate per year. That's very nice. You go to a district in Africa, you find out 30 years ago how many medical doctors were there, how many is it now, what is the growth rate? And you compare that to the economic growth rate. And you can't go faster than the economy. Don't ever put a project there and say, we just are humanitarians and the government should take it over, and then you place the resources up here and it's impossible for them to take care of it. Count, use Excel. Still, 2 medical doctors. My colleague here, not so experienced as Dr. Vernau there, he was qualified, really qualified surgery and general practitioner. Here, a little intern like I was 30 years ago. He didn't know much surgery, but he had these 2 ambulances now sending staff down here, very motivated, very nicely working. I could recognize myself. You see, poverty is running so fast in Africa. The poor population have 5 children, 1 dies, 4 survive, and it doubles in 20 years. Congo will double its population in 20 years. In 40 years from now, Africa will have not 1 billion people, but 2 billion people. And you have to get contraceptives out because African women are asking for contraceptive today. We have 25% unsatisfied need for contraceptive access. And you don't have to push family planning on anyone, just get women what they ask for. No big posters about family planning or anything. But population growth threatens health service access. So in 1981, when we thought we got things in order, we got a message from this health center. 19th of August, 1981, it's translated. This is Sister Lucia, a Portuguese nun working in the area since 20 years back. She said, last days, 30 women and children came to cover our health post with paralysis in both legs. I've never seen this disease before. Please come. I came then and asked her, how long have you been here? 20 years, she said. She had never seen the disease before. That's sort of scary, isn't it? And this is what we saw. Children with sudden onset of spastic paralysis of both legs with no sensory involvement at all. And we looked in the book, we found that Lathyrus sativa was not grown in the area. This was, to us, a new disease. We'd had an African submarine in the area 6 months earlier, and we thought this may be viral warfare. I didn't sleep for the following 3 nights. And This could be infection, hysteria, deficiency, or toxin. We didn't know what it was. It was an unknown disease, an outbreak of it. And we knew that that year, 1981, there was a severe drought, the worst drought in memory, in living memory. And there haven't been any so severe drought since then. So don't come and say that agriculture problem in Africa is climate change, that advocacy, exaggerations. There's severe lack of rain and rain-fed agriculture. There's so much stupid adaptation of the contemporary concept. African agriculture have its own problem in rural area without climate change. If climate change come, it will come severe in 10 to 20 to 30 years from now, but it's not now upon them. There's not been a severe drought during the last 30 years that we had that year, and people lacked food. So what we had to do a survey of this disease in the area. And we did it here, and we could find in the area, we could find 1 to 3% here. We could find 0 at the coast, 0 in the inland. It was caused by severe drought and no access to food either than toxic cassava. We found the same disease in Tanzania later. We found the same disease in Congo. The problem was, should you help these people or should you find the cause of the disease? It's a classical ethical problem. And then we found out, we called the disease Konso, what it was called is Zaire, and we found in this area in Zaire, we found identical cases all across Africa. It's me and the African institutions and colleagues I worked with, and this took 20 years. 20 years of research to do this. And this is you find something when you work in an emergency situation, you are bound to find new diseases, and you have to do research. But research cannot compete with the need to provide the health service. You have to step outside the normal health service and mobilize extra resources and put them at disposal for research. And do this. And then we could show very clearly that the disease started in Kinshasa, not by a drought, but by a road that changed the processing of cassava when people were selling cassava. And this is making a very long 20-year research process very short. In short, it was like this. The old mama here, she had traditional processing which took away all the toxin, and the young mother said, we have to shortcuts in processing of cassava because we want to sell when we get nice prices so that we can have money to put our kids in school. This was very, very severe poverty in rural areas, and it yielded this disease. And then we could find from extreme poverty to population growth to shortened fallow time, extreme workload, and it's 1 PhD thesis for each box here, and then you can present the new disease. That was the problem. The first ethical problem, you come into a situation where you have scarce resources and you need to do research. It's really a dilemma. It's really a dilemma. In Mozambique, in the urgent situation, it was solved by the Minister of Health sending a busload full of nurses who replaced our staff in the district so we could work with our staff and do that first survey. But you need to mobilize other resources. There's no way that you can use just the internal resources. That's my answer on this ethical dilemma. The first one I was going to make. How do you do research in extreme poverty? The second is, how do you do research when you have a political power that tries to control you? 1993, May, I got a telephone call from the Cuban embassy. We would like to meet you because we have an epidemic disease in Cuba, causing paralysis in the legs. We know what you have studied with cassava. We want you to come to Cuba. We flew to Cuba, me and my chemist. We landed there. We knew the tropical, or what they call epidemic neuropathy in Cuba, 40,000 cases with peripheral neuropathy, an eye problem. And then we went to see the Cubans, who are extremely capable epidemiologists and toxicologists and microbiologists. And we started to discuss with them. They presented their research, the uneven distribution of the disease in Cuba, most in Pinar del Rio province, where all the tobacco is grown. And we were discussing the middle of the afternoon, and the door opened, and Fidel Castro came in. How are you going to be an independent researcher now with the Cuban colleagues? But Fidel came in very nice, like Father Christmas, started to greet everyone. And then he came just to check my CV. He spent half an hour nicely talking, but I realized very soon it's just to check my team. He runs the country in a very inefficient way. So the president go and check the CV. I didn't grasp why he did it at that time, but it was nice, and he went away, and we continued to go around in Havana. We ended up in the evening with my host in the medical academy discussing the future study design. And I said, you have used quantitative epidemiological methods with dietary interviews. I don't give a damn for that. I want to use qualitative methods to really explore what people are eating in this catastrophe economic situation, because it was the disappearance of Soviet Union that threw Cuba down into economic decline. And we were discussing this intensively, how much you could use qualitative research in epidemiology, and the door opened and in came Fidel Castro again. And he sat down and he wanted to participate in the study design. So how do you do now? What I learned then is to define who you are. Define who you are. I'm not here to criticize him politically. I'm not here to support him politically. I'm a researcher. I come from my university in Sweden. I got humanitarian research funds from my government. I'll be researcher, very correctly. And he started to interfere and say, what do you say that there's no quality in our studies? We have studied this with the best of methods, you know. And I tried to explain, meu español un poco portuñol, so I could speak directly with him. And I said, this is not about bad quality, it's qualitative method. It's another type of research method we are using now. What sort don't we have the right methods? And how should I convince Fidel Castro that I wanted to use qualitative research methods? And I got the idea. You see, and I said, Mr. President, can I tell a story? And you know, in the Cuban culture, you can tell a story. This was in the evening. Yeah, you're welcome to tell a story. And I said, when I was a young student, we saw the film when you and Che Guevara came with grandma to start the revolution. Oh, you saw that film? I said, yes, it was black and white. Yeah, it was black and white. Did you see when we landed? He said, I can't recall that. That's good for you, because we couldn't film it, he said. When this typical idea of a dictator always checking, you know, and scaring you a little like that. So no, I didn't see that, but I saw when you lived in Sierra Maestra, you really lived with the people, to understand the people's situation. Yes, and you understood it. Yes, we understood it. And you cooked food with the women. Yes, we helped them with that. You helped the men to harvest. Yes, you read the homework with the kids. Yes, we saw all that in the film. But you know, one thing I didn't see. What was that? You didn't have any questionnaires, I said. How could you understand the life of the people if you didn't have questionnaires? And then you start to understand what I was getting. I just want to use the same methods that you did in Sierra Maestra. Los métodos de Sierra Maestra ahora es ciencia. The methods of Sierra Maestra now is science. It's qualitative research methods, participatory qualitative. Please let me do that. Let me live in those most affected communities and see how the food has changed. And it works. Next morning, the head of the armed forces and the Minister of Health gave me 6 months to do what I wanted with the team I picked in Cuba. Very interesting. You could stick to that. And then they wanted to have me in the TV and tell the people in TV how nice invitation I've got, and I resisted. You can't find me in any photo, in any newspaper in Cuba, in anything, because that would be letting the political power use me. Neither did I report anything back to foreign media, because that would be letting foreign media use me to talk back about the government. I had to decide that I was there only as a researcher. And I wouldn't use that in any political or advocacy way whatsoever. Then we could work very nicely with the Cuban colleagues, and we could see that it was indeed the desperate lack of food that had made the adult population eat a very monotonous diet with very little vitamins and very little protein, and that caused this disease. And Cuba knew it already in February, and they provided B vitamin, and the disease was gone, and we were invited just for a political game to show that they invited foreign researchers. But they treated us correctly, and we behaved correctly. So that was my second ethical dilemma I wanted to share with you. If you want to work in a very harsh political situation with research, decide that now I'm only a researcher. You can't do advocacy at the same time. You can't support the government in the same time. You have to try to be, and researcher is a sufficiently independent position, and you will get accepted. You will get accepted as long as you don't use it anyway to anywhere. And it's taken about 20 years until I stand on stage and talk about this, because now it's history. The third problem I see, it's what I'm involved with quite a lot today already. You came out very strongly with the campaign Access for All, for antiretroviral treatment and other drugs. And I like very much the analytical work done by Médecins Sans Frontières. But early on I said, it's impossible to treat all HIV infected in the low-income countries in Africa with antiretrovirals. And I was severely criticized for saying that. How is it today? How many of those who have been infected for 10 years with HIV in Zambia, Mozambique, Uganda, Malawi, in East Africa, those most affected low-income countries, I'm not talking about Botswana, Namibia, South Africa, which are middle-income countries. Because to me, economic level is much more important than color of the skin. So I don't talk about Africa, HIV in Africa. I talk about HIV in low-income countries and severely affected low-income countries, which has 5 to 15% HIV prevalence. How many is it that after 10 years get an AIDS drug into the mouth before they die in AIDS? What is the percentage? It is the figure to know, isn't it? It's the number to know in an organization where you have run this campaign. But it doesn't exist. It's 50%. I don't know, because I'm asking everyone who knows about it continuously in the last 2 years. Ministers of health, heads of program in Africa, scholars in Africa, those in the main organization. And I made this graph to try to explain how it is. 10 years ago, this is the cohort who got infected. First 5 years, no one died in AIDS. They are HIV infected, but there is a background mortality. HIV infection doesn't protect you for all the other diseases. So someone is dying here. Here you start to get CD4 low and you are eligible to treatment. And then here you either die directly or you start antiretroviral treatment, and then some may die on treatment. This is more or less the pattern, what you see in front of you, that we have today in the most affected low-income countries. But what is reported is this. This is the antiretroviral coverage. Green is those who are on treatment, and they are divided by those who are alive and eligible to treatment. It's this group. This is the dead doesn't count because problem is solved, isn't it? Have you realized that the coverage measure works like this? It's a very, very strange definition of coverage. To me, you can't have coverage on diabetes treatment. You must have coverage of those who start treatment and then survival on those who are on treatment. But we haven't reached that point because this measure is there for advocacy. It's not for monitoring. It's for advocacy. And there's nothing wrong with advocacy. I like advocacy, but I want some sort of balance. And we need to understand why we have now, especially since people now say, no, let's start to treat early because so many are sadly dying just the first year of treatment or even the first 3 months. So we want to get them with higher CD4. So instead of trying to reach out for these ones who die, the programs try to reach out here because they are staffed by clinicians who just think in institutions and not in populations. Because they are humanitarian, isn't it? So they use Word and not Excel. This is a severe criticism. Because we have to be realistic. And these people should be 35 years on treatment now to hear, more or less. It's very costly. Yes, it's a triumph that the prices have gone down as they have. It's a triumph. It's a triumph that it's so successful, this one. And it is really successful. But it is the better off, more educated, living closer to urban area, having a higher income, less stigma, who are more on treatment. The provision of ARV treatment in Eastern and Southern Africa has increased health inequity, not decreased it. There's nothing bad with that, because it saves a number person like me, it saves human resources. It saves investment in human resources. And it really saves the life even of some of my best friends. So I have nothing to criticize for this, but there needs some realism, at least in the center. You have to start to think, what do you want to achieve now in the future? Yeah, we hand it over to the government because it's too costly and too complicated, and we do something else. Or should this one be reached, or should be able to do something of the real thing to decrease the incidence of newly affected, which is what's most important. It's really a challenge to get the HIV situation now on some evidence-based footing. And even the other parts of the Access program have some problem. Let's look out a little wider outside Africa. These are two of my favorite. Hamid Yusuf, head of CIPLA, leading drug company in India, and Daniel Vasela, who had been the head of Novartis. He charged a little too much salary, so he went out with some shame, but I was careful in the wording there. And he has been very angry with Yusuf because he called him a pirate. And Yusuf is very angry because he called him a monopolist. Who is right and who is wrong? Well, this is Mrs. Balam, and she got leukemia. And she is a lower middle class woman who managed to get her kids through some sort of schools, and they are primary school teachers in India. And they took their mother to a doctor when she got ill, and there was an anemia, and they got her a little further. They could afford to have the diagnosis, leukemia. She can be not cured, but she can live for another 15 years if she gets Gleevec, this fantastic drug, which Novartis have developed. Now let's give Novartis credit, because this is truly a new drug which cure a formerly lethal disease. It's not a me too that so many big pharma do all the time. That they waste resources, he has to make slightly better and then have the patent for that for many years. When they came with Gleevec, it was really new. She admired this, give it, I want to see my grandkids growing up, but it cost $60 a day. It's impossible for her to pay, because she had to pay for research, not only the research for Gleevec, but also the research for the 8 projects that failed. Because otherwise you wouldn't have got this one. And that's fair. Someone has to pay for what is being done. If you have to pay for the profit, that's another question, but the research has to be paid for. So she turns around here and says, oh, Cipla is making this much cheaper. But that's because they do this generic, and they say, we are willing to pay a license for this, but we cannot pay this price. We respect the research, and we are willing to pay the license, but we want to negotiate the license. Now, there's one problem here. Can you see the problem? What is the GDP per capita of India? No one in the room knows the GDP per capita of India? Well, market exchange rate, about 1,500. Purchasing power rate, 3,000. This is market exchange rate. And how many people live in India? Well, if you have 1,500 per day, you have $5 a day, isn't it? This is still too much. She can't even afford this, if not someone else pay. Because this is what it costs to synthesize and produce this drug. And this is not something that cures in a week or two. It's a lifelong treatment. It's a real challenge we are facing now, because we have a new situation. And who in the world have the human right to get cochlear implant? Do you make death screening on all children born in MSF hospitals and give them bilateral cochlear implant? No, you can't do that. So that means that you are putting a level on human rights, isn't it? You know where the limit is in Sweden? It's here. 5 teeth, you get Titanic implant. From the 6th teeth and beyond, you pay yourself. I like clear cutoffs, isn't it? It's very clear, yeah? You have 5 teeth there, that's pay, that's human rights, then it's commercial. Every country have to put their limit. Don't even think that there's no limit. You have to put a limit somewhere, and you have to do that much more consciously than perhaps you have done in the past. Look here. This was not the one. I don't have time to show you more, so let me just show you this one. No, I have to show you, we do like this, and we take this, and we take income there instead. Come on now, fast. And here we go, and we take basic, we take life expectancy. Here we are, and we deselect, and we go backwards in time. Yeah, that was the old time. Money, survival, you know, and we will compare United States of America. There, they had 40 years life expectancy and $2,000, 1,800, and then we're going to compare them with Vietnam. You've all heard about the American War, don't you? I hope no one called it the Vietnam War. It's called the American War because the Americans who came to Vietnam for that war. So if you call it the Vietnam War, you are American. Huh? It's strange. Naming is very important. Huh? It shows how you think. This is how United States got richer and healthier, and this is how Vietnam got healthier and then richer. Can you see the distinctly different ways they took? Vietnam today have a life expectancy of 75 years. It's the same as United States have in the 1980s. Vietnam is today healthier than United States were when Senator McCain came home from prison. They've taken away the disease burden from infectious disease, and they now suffer from cancer, traffic accidents, psychiatric disease, and cardiovascular. But the economic level of Vietnam today is the same as the United States 1860. Isn't that something terrible? Anyone would volunteer to be Minister of Health in the country who have a disease panorama of 1980, an economy of 1860, and the population want the medical technology of 2013? It's just impossible. The whole change in the world has created now a middle-income countries where most people are living here, from India and China, 4 million people in the middle, who have a health status like in West Europe, like 30, 40 years ago, but still an economy like 100 years ago. There's no way they can pay for the treatment. There's no way they even can pay for generic cancer drugs. And it's so difficult to handle, isn't it? Because it runs counter for all our principles and all our thinking of human rights. So what should we do? How should we do to be more fact-based when we discuss this? How can we at least communicate this in a better way? I stopped there. There were 3 ethical problems I had. In severe emergency, you need research, you bring additional resources. When you meet harsh politicians, you stay researcher. And when you are an activist and you do research, you have to separate advocacy from research in some way and let them be linked to each other, but also have independency. Thank you very much.
Thank you very much, Hans, for a very entertaining talk. And we have the pleasure of being able to open up to the audience, both online and in the room, for some questions. I warn you, if you ask a question, though, Hans came in and he said, you know, you have to plan your strategy because this is an attack on MSF that I bring, and when I attack, I will win. So
no. I say I will choose the attack so that it has some result. I love the organization. I'm a permanent member. I contribute steadily, perhaps not much enough. But really, we have to think. I don't like Médecins Sans Frontières. I think the head think also is very good, not only Sans Frontières.
So I'm going to open it up to, firstly, questions in the audience. So if I can have hands up, and just please introduce your name and your organization. Down the front.
It's my real privilege to meet you after 20 years knowing your name and never seen you. In fact, I was working in same district 10 years after you were there, into 1991 to 93 in Nacala and Angoshe.
Did you have a motorbike? It was him, they remembered him.
Yes. No, I had a car, in fact. I was working with MSF, being a new and junior doctor. In fact, I was, in fact, sent to Nacala, and the medical coordinator called me the same day when I reached there, and he said, because there's an epidemic of tropical neuropathy at that time, and he took me to the health center that they were, in fact, collected the patients, and he asked me, do you know this because you're an African doctor? Do you know this problem? And I've seen the people, so many people dancing. I have nothing else I can remember I know before, and all I have to do is to just dance with the people. It was very difficult, and after that, we have to go and search literature, and where I come to see your name and other doctor, I think in Mozambique also. Cliff, exactly. And then followed, and after that, we in fact came to know the problem and diagnosis thanks to you.
Sorry, I don't mean to interrupt, but we have only a short time for questions. Do you have a specific question? And Hans is hanging around afterwards and will be on a Twitter Q&A for those who stay online. But do you have a question specifically for now?
Yes, I will. Okay, after you told me, in fact, told us that you went back to Mozambique in 2011. So still the neuropathy cases are there, or is?
Yeah, they're still there. The causes of CONSO is the collapse of the farming and food system that is entirely dependent on cassava. If you can't grow sorghum and maize, you move to cassava, which produce under more unfertile soil and less rainfall. And then when you expand your areas, you shorten the fallow periods. You don't have any fertilizer. There will come a harsh year when you miss your cassava, or you have to sell what you have processed, and then you end up in this situation. What exactly caused it, if it's cyanide or not, we don't know. But we know the process. And the solution for this disease is to end extreme poverty. That is the solution of this disease, you know. And perhaps there's need even some migration from those areas. There are too many people there. And some in MSF has come across this. I know you have done some report of it. The most important is to not think that it's an infectious disease. It's sudden onset. You get scared. When I've had the first days, what was it that took most of my mental capacity? I got so scared to get infected myself. I even stopped thinking. I evacuated my family. It was just that Catholic nurse, and I really have to pay tribute to the Roman Catholic nuns and nurses I worked with. They brought courage even to me with their prayers, though I don't believe in the other things they believe in, but I highly respect them, and they work for the people. So they were in these areas, but it's not infectious. You don't have to block the road. You don't have to isolate the patients. And you can rehabilitate them very well, but it never go away. They will stay crippled for life. And you can intervene in these areas with food security earlier on. It's still there, but not so much. The population is aware of it. It's a little like beriberi or pellagra. Is that terrible disease linked to exclusive consumption of one staple food in the bedway? It's no reason whatsoever not to eat cassava. It's no reason whatsoever not to grow toxic cassava, because toxic cassava is good. It protects the crop from theft. Because cassava is the only staple food we eat where we don't eat a reproductive organ. The cassava root doesn't sprout. It stays in the ground for a year or two. It has no fixed harvest time. It's a beautiful converter of sunshine to food, the best and most efficient converter. On my PhD dinner, I served well-processed toxic cassava to 200 people. And yet today, the spinal reaction of all aid organizations is, this disease is caused by toxic cassava, let's bring in non-toxic cassava. It's so stupid. Sit down and listen. It took me 10 years to realize that it wasn't me teaching small-scale female farmers, it was them teaching me. Humbly, I realized that they knew the toxics. They knew the enzymatic process, but they couldn't express them in chemical terminology. I had to be much more humble, and it was some of my female research colleagues who finally started to translate this. And I remembered sweet cassava in English, in Swahili is called muhogo baridi. Yes. And baridi means cool cassava. It's a Coke which you drink. It's something you eat fresh when you work in the field, but it's a toxic one which you make the enzima and you survive on. It's like the sweet banana and the cooking banana. You have to understand the food and farming system. And we who come outside, whether we come from Europe or we have grown up under nice condition in the capitals of Africa, we tend to be ignorant, you know, and look down upon female farmers. They are very clever on surviving in poverty, very bad of getting out of poverty. So that's in short. Read not only the abstract of the first article, read the full article if you run into Consul.
I'm going to take one more question, lady in the orange.
Hi, I'm Tish. You say that you still got this traumatic distress from the 00,
yeah.
And yet you asked us not to be ambitious over the growth rate in a country's economic growth rate, and not to be too ambitious as MSF or humanitarian organisations. Mm-hmm. Have you got anything more hopeful to offer us?
Yes, I can cite Ingegerd Roth, which is one of my other mentors. She is a Swedish medical doctor, worked 40 years in rural Africa for Pentecostal Church, to which I don't belong in any way, but I respect once more the ones who have worked there. And she said, the most important in poverty is to never ever do anything perfect. Because as soon as you have done one thing perfect, you have stolen resources from where they would have been better used. This is the tough thing. Never ever make any plaster useful. I remember I got an old woman who came in and she had a broken leg. In fact, she had an open fracture, and she was carried in, and I had no anesthesia. So you imagine an open underleg fracture, and we managed to repair it, and I put her in bed with chloramphenicol, you know, and all antibiotics we had, and don't get up for one day. Next morning I came to the hospital, she was standing in the door waving to me, and showing how well the plaster functioned, and I ran up to, you have to be in bed. No, I'm going home, with translations, she said. I'm going home because I have grandkids and hens and chickens I have to take care of, and I'm very hopeful. I just want to thank you. And then I saw that one foot was pointing that way, and the other foot was pointing that way. And I looked and realized that I learned that when you have pain and no anesthesia, you rotate your femur like this, and I had put the foot like this with inner rotation. So now she was like this, with 90-degree error, you know. And I said, no, you have to go back. I take away the plaster. We read that painful thing once more, never ever. You know? But if I leave it like this, you will never be able to walk normal. You will walk like this for the rest of your life. That's what I hoped for, she said. I know that everyone who gets the bones going out through the skin will die. I know that. Now you tell me that I'm going to survive. That's why I want to thank you. And I just want to go home and feed my chicken and take care of my grandkids. This is what I expected. Thank you very much, doctor, she said. And then she walked away. Listen to the patient, listen to the local staff, let them help you to set the standard, and then expand the service. That's what you should do. Don't make a tower of excellence just where you happen to have landed. Expand the services at the modest level, and don't intend to readjust. If you have a fracture on the leg should be straight. If possible, the foot should point forward.
I'd like you to put your hands together for Hans Rosling. Thank you very much.